Good morning, everyone. Welcome. As you get signed in, you'll be seeing a quiz pop up on your screen. It's just to see if you've joined with us before, but no pressure if you don't want to answer. While we wait, I would like to introduce myself. My name is Madison Burnett, and I'm a BCBA. I lead our professional development program, and I'll be supporting through today's webinar. In addition to that role, I work alongside other BCBAs on our clinician-led recruitment team, and I support in the effort of recruiting quality professionals to join our team. If you are interested in joining, please indicate so in the post-webinar survey at the end of this webinar, or you can email us at careers@manhattanpsychologygroup.com. All right. Also, before we begin, I'd like to just briefly tell you about Manhattan Psychology Group. We were established in 2011, and we've continued to grow our team consisting of skilled adult and child psychologists, neuropsychologists, behavior analysts, special educators, licensed social workers, and behavior interventionists. Our mission at MPG is to create a future where individuals and their families feel supported, connected, and empowered. And our mission is to provide multidisciplinary, integrated support for individuals and their families who experience mental health, behavioral, and educational challenges. For some housekeeping information about CEUs, those seeking CEUs for this presentation, you will need to attend in its entirety with a minimum of 100 cumulative minutes in order to receive a link for the post-webinar quiz and survey following this presentation. We will verify your attendance by reviewing the time attended logged in Zoom and send an email with the link for the post-webinar survey for all those who have met that minimum criteria. We will be leaving the chat open, but please post any questions you have for Amy at the end, and she will get to them if she does have time. And as some of you may have noticed, or you may have received an email, MPG is transitioning to Behavior Live in January. So we'll be hosting our synchronous webinars on Behavior Live, and the majority of our asynchronous webinars can also be found there. December is the last month to make any purchases on Thinkific. So if you do see any webinars there that you're interested in, now is the time to purchase them. Thinkific will be closing in April, so all courses that you have purchased need to be completed by then. And we also encourage you to log into your account and download any of your CEU certificates that you have earned previously. I will be staying on for a few extra minutes at the end of the presentation to answer any questions about that. Now I would love to introduce our presenter. Dr. Amy Davies Lackey earned her PhD in special education and applied behavior analysis from Columbia University Teachers College and is a board certified and licensed behavior analyst, special educator, and school administrator. She has 29 years of experience across diverse settings, including general and special education, juvenile justice education, parent education, and administrative and transdisciplinary roles. She has presented her work at numerous conferences and currently serves as the Executive Director of Education at the Manhattan Children's Center. She also serves on the editorial board for the Journal of Special Education Research, Policy and Practice, and she holds an at-large seat at the NYSABA Board of Directors and provides behavioral consultation to organizations and families. And now, without further ado, I will hand it over to you, Amy.
Thank you. Well, welcome, everyone. I'm so glad you could join me on a very cold and chilly Saturday morning. Today our topic will be talking a little bit about how do we create ethical programming for secondary age students through transdisciplinary collaboration and really why those roles are so critical at that juncture in our students/clients' lives. I don't have any conflicts of interest to disclose. But I do have a confession for our presentation today, which is that I have often sucked at collaboration. I really am trying to do better. So I did prepare several components of this presentation in conjunction with speech pathologist as well as occupational therapist. So the purpose of, as I mentioned today, is not for me to just expound at how terrible I have been in the past at collaboration, but really to talk a little bit about professional collaboration across disciplines, in the school, in the home, in the clinical setting, and how they've become critical in assessing, planning, implementing goals and objectives for our clients or students with disabilities. While the impact of professionals collaborating is great, the varied training, our theoretical perspectives, and backgrounds of professionals often lead to very different viewpoints on how to best address the needs of students with disabilities. So today we'll be diving a bit deeper into delineating some of the models of collaboration, the competencies, the ethical considerations, and the need for collaboration. And finally, a framework for collaboration and conflict resolution, as well as taking a close look at how that pertains specifically to secondary age students who are transitioning to adult services. So let's start off by differentiating and defining a little bit about collaboration and the concept of collaboration and distinguishing that from teamwork and cooperation. So collaboration is really defined as a team that is small in number, consistent with people committed to sharing a relevant purpose, um, with common performance goals, complementary and overlapping skills, and often have a common approach to their work. So at times, we are often using words like teamwork, partnership, working together, joint effort, but collaboration is deceptively simple concept with very wide-ranging and exciting implications for the education of students with disabilities, as well as the effectiveness of educators and behavior analysts. One of the defining features here that distinguishes collaboration is the mutual engagement in shared goals and interdependence, with the end result producing an outcome that no single party could have produced alone. That last part is really the important part to focus on. The result is a combination of a common goal and the interplay of skills that ends with an outcome that you could not achieve alone. There's been a lot of discussion about humility and behavior analysis, and true collaboration really means us abandoning our ego and the idea that we have the scope and the skills to address all the needs of learners by ourselves. Some of the definitions of collaborations may inadvertently suggest that the concept itself is very simple. Collaboration is anything but simplistic. At its heart, collaboration means giving and taking of help, shared expertise, observations, effective communication, and expanding our repertoires as BCBAs, and being reflective in what our areas of competency truly are, as well as having a shared purpose in creating our goals and a vision for improving socially significant behaviors, moving beyond territorialism and turfism, which has no place really in collaborative practices. At the end of the day, BCBAs, teachers, therapists, have to share a vision, one that's larger than themselves and is focused on their self-focused needs. When this happens, everybody contributes to and becomes a part of a community, with work taking on a new and greater meaning and sense of mission. Friend and Cook had an article in 1992 that defined a lot of the characteristics of successful collaboration as follows. The definition embodies guiding principles for the application of our code of ethics, and the application of these defining features of collaboration promotes professional behaviors that are aligned with fulfilling our responsibilities to our larger professional community by behaving with integrity. Collaboration has received considerable attention across other fields, specifically healthcare. Collaboration in healthcare has been shown to improve patient outcomes, such as reducing preventable adverse drug reactions, decreasing morbidity and mortality rates, and optimizing medication dosages. Collaboration has also been shown to provide benefits to healthcare providers, including reducing extra workloads, increasing job satisfaction. Within research, collaboration expands access to data sets, skills, expertise, funding, and expands the reach and impact of findings. Within the education field, collaboration is most commonly occurring in the development of IEPs for students, diagnosis of students, and additional collaboration with general education teachers, paraprofessionals, support staff is necessary to support our students' learning toward measurable outcomes and to facilitate students' social and emotional well-being across school environments and instructional settings. So for the purpose of today's talk, we're really going to focus on collaboration for students with disabilities, specifically autistic students, who are at the secondary age. And those who really require very substantial support. I think that's a very unique group of learners that are often overlooked in those, autism awareness days, often overlooked in the literature, and in a lot of continuing education that we do. We already know, for all of us who are working in this field, that ASD is a multifaceted, complex disorder that's created an unprecedented opportunity for impactful collaboration between specialized professionals, as autistic students demonstrate needs across each of these listed domain areas here. It's very restricted thinking on our behalf to believe that we alone can address all of these potential issues. The extensive diagnostic criteria for ASD highlights the need for a conglomeration of services across both the medical, educational settings to adequately address the needs of this pervasive disorder. Autistic students are also diagnosed with comorbid conditions related to physical, cognitive, and mental functioning, and physical mental comorbidities associated with ASD include epilepsy, sleep disorders, gastrointestinal disorders, hyperactivity disorder, feeding or eating challenges, obesity, anxiety, depression, bipolar disorder. I'm sure each of you have experienced opportunities for education with families in any of these areas or opportunities for goals for your students and clients. This spectrum of need creates an even greater necessity for the provision of effective treatment, one that defined within our code of ethics is supported by empirical evidence that is individualized to the person in order to address the deficits and promote independence. So let's take a look at 3 approaches that provide a framework for partnerships: multidisciplinary, interdisciplinary, as well as transdisciplinary collaboration. Within special education and applied behavior analysis, 3 approaches provide a framework for partnerships. As I mentioned, multidisciplinary, interdisciplinary, and transdisciplinary collaboration. Critical variables across these models contribute to successfully transferring skills and knowledge during school collaboration. At the foundational level, each model provides a structure for an outline for interaction between team members, with collaboration aimed at creating comprehensive support system for students or clients that combines a knowledge and area that transcends professional boundaries. The aim of collaboration, as it pertains to individuals with autism spectrum disorders, is that those in need of our expertise and services benefit from comprehensive support system that combines our knowledge in areas that extend beyond the rigid boundaries and professional boundaries that we've set. So this collaboration is most critical when the students are at that secondary age, right before we have to prepare them to leave services. We're going to talk a little bit later about what that transition from the intensive services that we've often been providing looks like for many of our learners. So our first model, multidisciplinary collaboration, involves professionals that work separately and independent of one another. This form of collaboration includes converging assessment results and intervention outcomes from the perspective of individual disciplines. Still, it doesn't include joint planning or intervention. It involves limited professional interactions with the assumption that only those trained in a specific area have the expertise to assess or serve the student or client. For example, the OT is the only professional maybe working on handwriting because they're the only one trained in assessing and addressing those fine motor skills. The continuum of collaboration also includes increased interaction through interdisciplinary collaboration. Interdisciplinary teams include professionals who discuss and share perspectives to set goals and identify intervention priorities with the purpose of providing less fragmented services. Disciplines assess independently of one another, but may engage one another during assessment, program development, as well as intervention. Boundaries, however, still exist between the team members who control the flow of information, as well as collaboration and implementation. So, for example, interdisciplinary teams include professionals who discuss and share perspectives to set goals and identify intervention priorities. They collaborate and communicate for assessment, intervention, with the aim of providing less fragmentation of services. Our third model, though, transdisciplinary, our transdisciplinary teams involve an even higher degree of collaboration. Team members coordinate and collaborate for assessment and intervention, and frequently and consistently, professional boundaries are blended. For example, this model includes an arena assessment in which one professional serves as the facilitator to interact with the child or perform the assessment while the other team members observe. The observing team members may also ask the facilitator to present certain tasks to the child, but they may not interact directly with that student. Professionals assume very flexible and professional roles, and they have to be comfortable with a degree of role release and sharing the different tasks across each of our disciplines. Professionals in this model also have to be able to engage in systematic cross-disciplinary information sharing for planning and intervention for this to be successful. Intervention and goals are to be determined jointly, and the responsibility for documentation for student outcomes is also shared. So you can see the degree of collaboration becomes even more and more intertwined with each of these respective models. With the transdisciplinary model, this collaborative structure has some notable benefits that the other two models really don't share. The knowledge exchange across disciplines has a strong student and client focus that incorporates parent participation, resulting in less confusion and intrusion into family life. The shared responsibility results in cohesive intervention plans that incorporate skills and knowledge of different specialists, the coordination of services, and more efficient and cost-effective services with this structure. This model is one of the defining features of collaboration, but I think what we have to really think about is not just how we're collaborating, but who exactly are we collaborating with? Amongst collaboration with other behavior analysts, BCBAs often find themselves working with other professionals across disciplines within inter or transdisciplinary setting, specifically when collaborating for autistic individuals. This often involves combining the strengths of multiple disciplines in order to maximize client outcomes. With these collaborations, we have the opportunity to work closely with speech pathologists, psychologists, occupational therapists, special educators, physicians, nutritionists, and others to improve educational outcomes and increase treatment fidelity. Successful collaborative education and treatment is predicated on the understanding that the value and expertise offered by different disciplines requires mutual respect and professional dialogue. Once again, let's focus into a micro level on the collaboration of professionals we interact with in schools, specifically speech therapists and occupational therapists. One of the most critical questions I get working in a transdisciplinary school is, do you really collaborate? Do you have buy-in? How do you really get along professionally? And the truth of the matter is, it took a long time. It really took also the right professionals to get where we are today, which is being able to engage in largely effective collaboration. I say largely effective because we are all human. We have moments where we're not so humble, or we sometimes engage in a game of this is mine, that is yours, when it comes to something like who's responsible for verbal behavior targets or communication development. Very often, the source of our misunderstandings or our conflict is differences in terminology and lack of understanding about the scope of practice and competence of other professions, such as speech pathology. These differences, however, are super impactful to the clients and students that we serve, and it leads their caregivers to have misconceptions about applied behavior analysis and speech therapy alike. There are pathways and common ground, though, when it comes to how we can foster collaboration between speech pathologists and behavior analysts. There are some specific suggestions by Koenig and Gerensser to promote collaboration between speech and language pathologists and behavior analysts includes sharing of treatment efficacy data, sharing innovative teaching procedures, sharing information about our area of expertise, sharing stories of successful collaboration, reading journal articles from another profession to gain understanding about scope of practice, potential overlaps, sharing concerns about unsuccessful collaboration efforts, and discussing and defining roles with each other over things like lunch. So, some of the pieces that we have implemented to help foster that relationship is having things like journal clubs where we can share articles about, things that we often have misconceptions about with each other's fields or with tactics or strategies from each discipline. Another discipline we often intersect with in the scope of schools and clinics are occupational therapists. Collaborative practices in the literature is somewhat limited, which speaks volumes to the chasm that exists between our disciplines. But there are many domains that cross over into ABA as well. OT practitioners have the knowledge and skill set to address many of the difficulties that autistic individuals face. For instance, occupational therapists address activities of daily living, such as feeding, dressing, grooming skills. These become more and more prevalent and more important and critical to teach, especially as our students are aging into adulthood, where independence is paramount. Occupational therapists, practitioners also work with an individual to improve processing skills, like those organizational skills, teaching calming strategies, working on visual perceptual skills. OTs have the knowledge and use of various adaptive equipment, such as modified utensils for feeding or adapted dressing equipment, such as specialized zipper pulls. When it comes to habilitation, OTs are skilled on how to modify and adapt the environment in order to promote independence with those goals. And these priorities should intersect with our field. We have even recently utilized crossover with occupational therapists in a bakery that we opened that utilizes and provides opportunities for our students to engage in baking, customer-facing sales within the bakery. And those occupational therapists very often look at everything from a different perspective than us as behavior analysts for repetitive motions, things that create physiological issues for many of our students, things that we just don't think about. So having this crossover is so critical. Unfamiliarity also prevents engagement and misunderstanding. Mutual perceptions and misconceptions of ABA and OT alike disrupt collaboration, when in fact, there is common ground. Both of us are skilled in analytic observations to help support clients. OTs are trained in activity analysis. We're trained in applied behavior analysis. OTs do use informed practices, evidence-informed practice. They value and are ethically bound to use evidence-based practice. And we're making those database decisions to track changes over time. This enhances rigor and strengthens evidence for both of our fields. We both value and understand the importance of routine and consistency for clients. Aversive behaviors can also occur because of sensory processing issues. OTs have the skill set for addressing those sensory processing issues. We focus on those problem behaviors and can do so collaboratively with occupational therapists. Both professions also consider environmental context and how it shapes the behavior of individuals. OTs utilize the person-environment occupational model to consider the fit of environment for the person. ABA considers environmental factors that influence behavior. So there is common ground here when we look carefully. Literature from both of our professions emphasize collaboration in a client-centered approach. So OT practice can augment ABA outcomes because it offers features not typically considered in in ABA. So OTs understand sensory responses, reflex patterns. ABA promotes behavior development through reinforcement. And together, they can choose the most effective behavior to reinforce for the individual. Our principles can be applied for more effective and evidence-based implementation of sensory strategies. Our principles suggest that the timing of sensory input strategies is critical, and they're trained to realize the unintended reinforcement in a client's environment and provide consistency with therapy. Some behavior analysts might not understand the appropriateness of therapeutic activities in utilizing sensory processing strategies. Very often, conceptual challenges, differences in our terminology, misconceptions about each field make it really difficult for us to collaborate within our two disciplines and to view the individuals serve similarly and it creates difficulties for the development of education and treatment plans. We have differences in terminology. Since sensory strategies are well understood and widely used by OTs, they may need to advocate for that form of therapy to the ABA professional when it's deemed appropriate for their client. So our misunderstanding of roles, philosophy, overlap of scope of practice often becomes very tangled and does not lead to effective collaboration. This is especially highlighted when we have families where you have to prioritize client services. If clinicians cannot effectively communicate collaborative potential to families, they may choose one service over another rather than a combined approach. The difference in our child-centered approach versus adult-direct approaches is also another barrier to our effective collaboration. But the vast knowledge of environmental accommodations and strategic use of equipment to address challenges is where we can find common ground. Both disciplines can address automatic or sensory-based behaviors and provide a context for collaboration when examining matched sensory stimuli or other reinforcers. OTs have the knowledge and task analysis as well with adaptive equipment to help our students and clients achieve independence or lean on their expertise that will get the student or client there more quickly. I like to think of this with respect to a lot of work-based tasks, as we've have many secondary students in our setting. Occupational therapists have really, I think, opened our eyes as behavior analysts to all the accommodations that individuals can have as they enter the workforce, volunteer opportunities, or even living in a residential facility or going to day hab, for example. Very often, I think we, as behavior analysts, felt that a lot of prompts needed to be faded. Our students had to be completely independent, and the reality is that there were a lot of accommodations that can continue to exist for an individual as they enter the workforce or as they enter volunteer opportunities. And the occupational therapist really had a better scope of an understanding of what those opportunities look like and what those accommodations could be. And also looking at the environment very carefully to analyze what do we need to facilitate a level of independence in the highest level of independence possible for the students or clients that we serve. So I just wanted to pause for a second. I wanted you to think about successful collaborative relationships you've had in your life, both personal and professional, and think about some of those keywords. How did you collaborate? What made those collaborative partnerships work? So take 10, 15 seconds just to jot down a few of those words for me. When we think about what does successful collaboration look like, we think about whether we were able to have student-focused views of instruction, keeping our eyes on the prize. Who is the most important person here? Successful collaboration also includes being able to reflect on student learning and thinking about what our knowledge of that curriculum or pedagogy is for us to be able to share our expertise. Successful collaboration also means being able to implement suggestions quickly, demonstrate interest in new ideas, and be knowledgeable and have student-friendly beliefs about behavior management and be willing to try. And sometimes it is about being willing to try, being willing to take that risk and find a way to measure and for us to use data as a common ground for collaboration. While the interdependence and level of collaborative team may vary depending on the model employed, collaboration is only advantageous when the outcomes surpass what could have been achieved working alone in isolation. ABA is not a one-stop shop, and the scope of practice and expertise of teachers and therapists alone are not broad enough to meet the complex needs of students who have multiple areas of deficit. Siloed services result in divergent paths across disciplines and waste valuable educational and therapeutic time, and it decreases families' confidence in our practice as behavior analysts. For secondary age students, I like to use the phrase, people say often when you have a baby or a small child, the days are long, but the years are short. Students who are in need of very substantial and significant support, those autistic individuals who often are diagnosed as level 3, needing that significant support, take so many opportunities to respond, to acquire skills. So being efficient is paramount. We have very little time to teach a lot of material. Collaboration matters for our students. We have to be able to maximize those outcomes. We have to be able to provide consistency across each of these areas. And the fact is, we often don't play nice. All the kids on the playground know. And social media, I think, has offered a platform for a lot of people to tell everybody about that. We have a PR problem in ABA with what we do. And we need, as a field, to do what we always tell parents to do with their kids, catch them being good. And the best way to do that is for others to get to know who we are, what we care about, and what we do is good. Collaboration matters, though, for expanding our own professional roles. As I noted earlier with healthcare fields, in our own field, it increases our job satisfaction, and that reduces staff turnover, which is a problem across our entire field. There's a shift in feeling supported, and it reduces burnout when we're working together rather than against each other. And it increases our ability to consistently communicate with families. It also creates efficiency. There's a reduction in unnecessary duplication of services. It increases problem solving and the ability to identify problems and develop solutions early and efficiently. For secondary age students, though, this collaboration matters the most. It means that we have comprehensive service provision, where we have no areas of need that are overlooked, goals that are reinforcing one another, and knowing that time is of the essence. Like I said, our students require many, many opportunities to respond to actually acquire new material. So when we're working together, we can provide multiple opportunities to respond. We have multiple opportunities for generalization and looking at that from each different perspective across our different disciplines. We also are providing consistency in our contingencies, which leads to better behavior outcomes, our goals, as well as our behavior plan implementation. We know that problem behavior isn't isolated to one person or another. It often occurs across each of our disciplines. So the more consistent we are in addressing that and creating consistent, effective contingencies for our students and clients, the better their outcomes are going to be. It also allows us to provide consistency in functional communication opportunities and communication priorities. Very often when we're with many of the students that we work with, communication is one of the core deficits that we encounter. So being able to really have consistent functional communication goals that are utilized again, across multiple different settings and multiple different activities, is a pathway for our students to acquire those skills more efficiently. It creates more opportunities to respond. And then we also are creating, again, those consistent recommendations across each of our disciplines and creating overlapping goals to support the family and student, and as well as coordinated communication to families. So let's talk a little bit of what it takes to have a successful team. The first piece is role clarity. Sometimes doing what is in the best interest of clients most efficiently will require team members to really step outside their traditional professional role. For teams to operate collaboratively, it's essential to establish clarity in the roles of each team member. Operationalizing these roles provides a framework for structuring the contributions of each team member and creating a comprehensive plan that includes shared decision-making and shared responsibilities. The second component is creating trust and confidence. Exposure to other disciplines and the opportunity to work collaboratively has been shown to facilitate awareness and appreciation for interprofessional roles. It's more likely that members of a collaborative team will develop a mutual trust if they are aware of other professionals' roles and witness their capabilities firsthand. The third piece is the ability to overcome adversity. Adversity and challenges are part of service delivery, whether it's complex clients or students or dealing with staff shortages. It's during those difficult situations that collaboration becomes more essential, and it's in the face of adversity that the team's true integrity is revealed. When teams are faced with adversity, the tendency can be to pass blame or begin to question the system, or management, or leadership. Challenges require every member of that team to remain committed to the ultimate goal, which is, in the case of behavior education, is client care. This also effective collaboration also includes the ability to overcome personal differences. It's not always possible to get along with every team member, but how those differences in opinions are handled is what truly matters. Team diversity should be viewed as a strength, and it should bring about different viewpoints, facilitate innovation and problem solving, and have the potential to result in amazing outcomes for our clients. The key is for everyone to be working toward a common goal, have a shared vision, and a shared vision of how we're going to get there. And the last piece is just having collective leadership that takes the pressure off of one individual and disperses it throughout the group. Professionals who bring multiple perspectives to the team are critical to collaboration. Still, working in teams presents challenges related to interpersonal skills like respect, confidence, attitudes, and beliefs that impact student progress toward shared goals. Establishing and guiding principles such as open communication, equity and participation, and a commitment to resolving conflicts fosters successful team collaboration. Also, creating a unified system of support and collaboration requires leaders to establish roles for each therapist, teacher, specialist, behavior consultant. This allows individuals to work within a defined role and creates clear professional boundaries within each scope of each person's expertise and practice across their disciplines. The knowledge of curriculum and understanding of the scope of practice and benefits the collaborative process at the end of the day. So we need to examine the effects of assumptions on our own personal perspectives and bias and on the needs of our students and clients, which will assist us in ethically and thoughtfully blending and refining instruction and interventions to be complementary to the services that are being provided to our students and clients. We've been talking a lot about effective collaborators, but we know that there are pieces that come along with also ineffective collaboration. So unsuccessful collaborators, on average, take longer to grasp and implement ideas. They need greater explanation. Those who were moderate to low adopters of ideas were less knowledgeable. Their implementation was poor, and they discarded ideas that they just didn't understand. A little bit of throwing the baby out with the bathwater, so to speak. While we all start with the best of intention, the truth is we don't play nice with others very often. But why? There's plenty of playground friends and equipment to go around. So when we look at the literature and some of the surrounding collaborative practices, there's clear barriers to that collaboration. The first is that our theoretical underpinnings diverge, and so do our treatment practices very often. And this leads to differing perspectives on goals as well as interventions that we create for our clients and students. These differences in theoretical perspectives go deeper though. They transcend into differences in the outcomes we expect, multiple approaches to targeted strategies, and a little bit of what I like to call this is mine, that is yours, professional territorialism. Professionals in our field often tend to work in silos, mainly consulting with those who are within our own professional boundaries. So, for example, BCBAs consult with other BCBAs, and oftentimes we struggle with communicating with other disciplines. And because BCBAs can develop strong ties within our discipline, they may think of within categories of in group, out group. And those in group or those of the same profession trust and favor each other and withhold information. They're the gatekeepers of information, right? And they hold that from other professions who are in the out group. Should be noted that this doesn't mean professionals behaving this way do it intentionally. Sometimes behaviors like working in silos are part of organizational culture. So it's hard for individuals to break down those silos and reach over those lines. Most critically, collaborative practices extend to caregivers and, if executed properly, result in meaningful program development and sustained engagement across improved outcomes for clients. Doctors Mary Jane Weiss as well as Dr. Bridget Taylor have both had several presentations as well as articles that really provide guidance on how we can engage in compassionate care. And that notion extends to collaborative practices in how we demonstrate core principles of our ethics code in treating others with compassion, with dignity and respect, as well as effective collaboration, whether with professionals, caregivers, or even our clients and students. It involves a significant amount of each of those characteristics defined by professional collaboration. Dr. Taylor and colleagues' work included a survey of caregivers that included parent perceptions of relationship variables. When we examine the breakdown of these items, these can be applied to any of our professional relationships with other caregivers. Dr. Mary Jane Weiss has also had a recent piece with ABA collaboration with occupational therapists that also had some very less than satisfactory results with respect to our collaborative behaviors. So when we examine the breakdown of those items, each could be applied to any of those professional relationships. Things like listening and collaboration in the therapeutic relationship. So being able to compromise and agree. Items that convey empathy and compassion in our therapeutic relationship. So being able to acknowledge our own mistakes and shortcomings. And items that contribute to problems in the therapeutic relationship, like having our own agenda, whether it's for a child's outcomes or therapeutic outcomes, and having an authoritarian demeanor rather than a collaborative one. So, where do we fail specifically? Very often with families, it's about avoiding inclusion of the parent. Verbal behavior about the science goes right over parents' heads. Insistence on being correct or having our own agenda of priorities or not sharing what we're doing. Lack of information to parents or other providers. For each of those items, they're items that convey empathy, compassion, and also can have harm to the therapeutic relationship when we fail to disclose things like treatment plan, including parents and part of that treatment plan. The fact is, when we fail to collaborate with caregivers and even other professionals, parents find somebody who's willing to back their view. It results in stagnation of progress for our students. And parents start to make assumptions about applied behavior analysis that are inaccurate. It also results in failure of parents to adhere to treatment plans or behavior plans. Parents don't acquire skills to be effective teachers and advocates of their children as they age out of schooling at 21. So again, coming back to those secondary age students, when we are gone from those students' lives, as they age into adulthoods, their families are still there. They are going to need to be able to know how to address each of these skill sets on their own. So we have to be able to empower them. Without that collaboration, we're not going to be able to do that. When we don't collaborate, we also are just consuming lots of resources and creating potential harm to the students and clients that we serve. Collaboration with our clients is also critical. It's about acknowledging personal choice in service delivery. And it's important for clients and stakeholders to be able to make informed choices. And sometimes respecting choice and their right to say no or make choices that you sometimes disagree with. I've had students where I felt maybe a nutritional piece, I had a student who was very, very obese. It was starting to affect his health and his ability to participate in activities at school and participate in activities of daily living. And we worked very hard as a team to talk to the family about why that was critical to the student's success and well-being. And the family respectfully declined to address that. And that was a really hard piece for, I think, as a behavior analyst and an occupational therapist and speech therapist, it was hard for us as a team to accept. But it was also about accepting that that was the child's parent and they had the right to make that choice at that time. And that part of our responsibility as behavior analysts is to inform them with the why. And that is often challenging, is respecting the right to say no. But when we collaborate with our clients or with their families, we also increase social validity in our consumer and satisfaction. We have goals and procedures that are acceptable to clients or caregivers, which means that they're more likely to implement those and more likely to follow through with those pieces that we're asking them to. It's also about respecting and actively promoting clients' self-determination to the best of their abilities. So I recently had a student who was working in an internship, and we had been working on self-advocacy, and we've been working on this in collaboration with the speech and language pathologist and teaching the student to identify what he did and did not like. And recently, in lieu of having a giant behavior episode, if you will, in his internship, he said, I hate this. I hate this job. I don't want to do this anymore. And we were like, okay, great. Like, thank you for telling us. You can do a different job, but it was about working together, giving him that functional communication and collaboratively teaching him those responses for him to be able to say that rather than eloping from the internship, streaming, hitting somebody, engaging in all these problem behaviors. He was able to effectively say, I don't like this. I hate this. And us to say, okay, let's look at what you don't like about this job. You don't have to do this job. You're not required to. We were trying to teach you a new skill set. It was something that he seemed to show some interest in, but it was about also integrating his interests into what he is doing and providing him with the skill set together to make those choices. And the focus really here is on teaching skills rather than efforts toward normalization or suppressing ASD-related behaviors. It's about helping kids who maybe can't communicate or talk engage with other kids. It might be about promoting self-advocacy through just basic choice making. And that is an empowerment in itself that we can all work on collaboratively, whether it's choice making in occupational therapy or speech sessions or any of the programming that we're doing for our students, even secondary age students. It's about teaching them how to make choices and demonstrate, and voice preference. I like to call it promoting voice and choice, and that is a really critical piece for our secondary age students, for all students, in fact. And that also communicates our respect in empowering and our respect for their dignity as well. We also have components across all of our disciplines that shape ethical procedures and collaboration. So community laws, prevailing philosophies, individual freedoms. As BCBAs, we have a responsibility to act in the best interest of our client. But, who is the client? Clients in a school are students, but it's very often more complicated than that. We have teachers, we have therapists, we have other ancillary staff that may be asked to help implement different treatments or different skill sets that we're trying to teach. In homes, we have caregivers who need to implement the treatment. Are they the client? So remaining client and student focused is a tricky business when there are a lot of cooks in the kitchen. Behavior analyst practice is informed by a set of universal principles that govern learning and behavior. However, knowledge of universally acceptable principles doesn't translate to an unconstrained scope of practice or an unlimited scope of competence. Scope of practice is only the set of activities that a licensed behavior analyst or certified behavior analyst is authorized to engage in. That authorization is also predicated upon the professional being competent. Just because one is authorized to practice relative to a specific procedure and population and setting doesn't mean you're competent to do so. I would say that the reverse is also true. Just because one specific procedure, population, and setting does not mean they are authorized to do so. Our code of ethics also includes 4 foundational principles, one of which being ensuring that competence includes seeking training, consultation, and supervision to increase our ability to evaluate the boundaries of our competence, as well as become better informed about the best practices and interventions across disciplines we collaborate with. Additionally, the ethics code speaks to practicing within our defined roles and within our scope of competence. The code, however, is not restrictive to cross-disciplinary training and to better understand the practices of our collaborative partners. So the scope of practice within speech and language pathology comprises 5 different domains of practice and 8 domains of service delivery. So professional practice domains include advocacy and outreach, supervision, education, administration, and leadership and research. Their service delivery domains include counseling, collaboration, prevention and wellness, screening, assessment, treatment, modalities, technology and instrumentation, and population and systems. Presented here are some of these SLP delivery areas. You can see that includes speech production, fluency, cognition, voice, auditory habilitation and rehabilitation, as well as language, so spoken and written language, resonance, feeding and swallowing. This list isn't even close to comprehensive, but you can see where that crossover is into areas that we often address with our students and clients. Within the domain of practice of occupational therapists and occupational therapy assistants, we often encounter things like activities of daily living that are oriented toward taking care of one's own body, completing those particular skills on a daily basis or routine basis, like feeding or dressing or bathing. Instrumental activities of daily living. So those are activities that support daily life within the home and community, which require very complex interactions like household management, financial management, childcare, as well as health management. So activities that are related to developing, managing, and maintaining health and wellness routines, including self-management, or the goal of improving or maintaining health to support participation in other occupations. Things like medication management, social and emotional health promotion, as well as rest and sleep activities, being able to get restorative sleep, including identification of need for sleep. And then finally, areas such as work. So those activities that our students often need for engaging in employment or volunteer activities that may or may not have financial benefits to our clients, as well as play. So activities that would be for our students motivated, hopefully motivating, engaging in leisure activities and expanding those repertoires, as well as the social repertoires of um, and expanding social interaction with others. Within the domain of practice, occupational therapists and assistants, um, they influence engagement patterns and the skills that the client uses across multiple activities. Um, our those OT practitioners use their knowledge and skills, including therapeutic use of self, to help clients conduct and resume daily life occupations that support their health throughout the lifespan. So, very often, our expertise of tactics needed for our students and clients to acquire these skills is robust. So combining our superpowers with the habilitative areas that occupational therapists cover is really paramount for our students to progress and for them to have meaningful growth across emotional, psychosocial, cognitive, and physical performance. So with such broad scopes of practice, there's room for crossover and collaboration, but it breeds territorialism. Within schools, resources can add to conflict and place limitations on collaborative practices. These factors are crucial in addressing pragmatic and logistical issues that hinder professional collaboration. One such barrier is the lack of dedicated time for collaboration. To address this issue, supervisors and leaders can work with professionals to determine topics for professional development related to collaboration, assess the amount of time required for effective planning, and identify a reasonable level of collaboration that can be expected from teachers, behavior analysts, and other therapists. It's essential to recognize that training received by teachers, BCBAs, and therapists has focused mainly on pedagogy and relationship building rather than effective collaboration. And so it's critical that we provide training on those skills and have ongoing mechanisms for supporting that. We'll have a few pieces at the end that I have tried to integrate into this talk today for giving some ideas of how we can do that, how we can integrate that into our day across a variety of different environments. While each of our disciplines are tasked with beneficence to the student and client, the very philosophical underpinnings of our field, like the lack of understanding of the tactics and procedures within each of our disciplines, cross-disciplinary training, as well as the time to resolve those differences, become inhibitors of collaboration. Within our code of ethics, behavior analysts prioritize clients' rights and needs in service delivery. And part of that prioritization includes effective communication about the procedures that we're using and the desired outcomes so that in a way that all stakeholders can understand. And this sometimes means us leaving behind the jargon of our science so that our collaborative partners can understand what we're talking about. Our code of ethics also addresses that before intervention, behavior analysts should describe in writing the objectives and procedures of behavior change intervention, projected timelines, and schedule of the ongoing review. This includes providing explanations and writings in a way that all parties can understand. With this, we also meet another component of ethical service delivery in being able to identify the conditions that interfere with service delivery and the discord about the foundations, the strategies of success, or the implementation of a plan that create barriers to successful treatment and/or collaboration. Ethical challenges in evidence-based treatment can also present a window for conflict. Before designing or selecting behavior change interventions, behavior analysts select, they design, assessments that are conceptually consistent with behavior analytic principles. But in collaborative practices, this can be challenging because we often have very different benchmarks of evidence-based practice. So education and cross-disciplinary training is very key in understanding the philosophical underpinnings, rationale, and perspective of different disciplines. Walk in the Woods is a four-step negotiation process to solve conflicts in healthcare settings. And it's a piece that can be easily implemented across many of our environments where we're serving students or clients. It encourages understanding of similarities and differences of opinions. The approach is solutions-oriented, and it helps parties involved put aside personal interests for an overall positive outcome. This approach can be effective with large teams of providers or helping you work through, say, differences with the team. So, for example, self-interest is not to be confused with selfish interest or being concerned about personal advancement at the expense of others, but it starts by defining the problem and then thinking about who has a stake in the problem, who has a say, or who will be impacted by the outcome. Each party defines the problem, what interests they have in the matter, and their end goal for those negotiations. And all parties are encouraged to listen to one another and not be judgmental. So everybody showing an interest in what others have to say. In step two, each person or group identifies what everyone agrees on to reframe the problem and what everybody disagrees on. The idea is that by first identifying agreement, it's much easier to resolve disagreements, which may now seem more unimportant. Parties can focus on what they have in common and what ways they're united. For example, what do all the stakeholders agree on? What do they disagree on? In step three, the parties freely brainstorm and create new ideas, creative ideas to solve the problem. No one judges or comments on the ideas offered. Everybody thinks about solutions in light of how detrimental things could be if the problem isn't resolved. I often, in utilizing this process myself, like to throw out the question of who will lose here? Most likely the person who's going to lose out if we can't find things that we agree on is going to be our student or client. So once everybody's resolved those, has offered some of those solutions, they're ranked. So unanimous agreement, ambiguity, clear disagreement, for example, and solutions might also be ranked on feasibility, time frame, buy-in, and importance from each party. The final phase, which is aligned interests, the parties work together to come to a mutual solution in agreement. All parties begin by defining their priorities, and they share what they must want, what they would like to receive, and what they're eager and willing and unwilling to give on. The idea is that all parties remember why they are having the discussion and what the shared interest is. Again, this I think is really critical in keeping client-centered focus. So our effective collaboration involves a couple pieces, as we've been talking about. Confidence in our partners' skills, designing learning environments for both educators and students that has active involvement, and creating learning and teaching environments in which each person's contributions are valued. And that is very difficult sometimes. It's hard to let go of the things we think or believe are to be true, but work to find common ground so that we can move forward. The next piece is it requires some level of truth assumption. Sometimes realizing that we're on somebody else's turf. We are one of many. And that they may have limited prior experiences with students with problem behavior. We may have, as professionals, there may be people that are working in our field that also have limited experience managing specific problem behaviors or managing a classroom. So developing these initial relationships is a very fragile process. It's thinking about also how do we communicate? What is our preferred communication style? And what is going to be the most efficient for all of us? And again, we'll come back to some suggestions of how we can do that in a very standardized, predictable way to have a platform for discussion. And being consistent and reliable with our communication, promptly communicating changes in schedules, being able to reschedule dates and times for collaboration, limiting our jargon, starting with I messages rather than you messages, actively listening and hearing out what they're saying rather than talking over or waiting to speak, attending to some of the nonverbal cues. I have sat in many meetings with other professions and watched their faces or their posture and realized that there's a level maybe of defensiveness because something we're saying is stepping on someone's toes or their professional areas of expertise. Encouraging, requesting, even pleading for, and promoting questioning of our information. And if you can't find an answer, be honest. Be willing to be vulnerable and say, I don't have the answer to that. Let me find out and I'm going to come back to you. Don't be afraid to ask questions, as well as monitor how much you are talking. Again, part of this is about actively listening to other professional perspectives and remembering that there can be more than one right solution. Very often in collaboration, I've come to realize that there are a multitude of correct options, and it's about us agreeing which one we should take first, next, last. Provide positive reinforcement. This is what we're supposed to be good at as behavior analysts. Send shout out notes to the other team members. In our faculty meetings and our organization, we always start and end with shout outs for students, for faculty. And doing that across disciplines. Incorporating communication notebooks, Google Docs. There's so many platforms for communication nowadays. We really are not limited. And when team meetings are scheduled, letting the team know what needs to be covered and working together to prioritize that so that we all have an equal share in communicating information to families. So, what does that effective collaboration also require? It's about a truth assumption, shifting our focus from proving we're right and therefore somebody else is wrong to understanding the other person's perceptions, interpretations, and priorities. I don't know if many of you have watched Ted Lasso, which was on quite a few years ago. But for background, Ted Lasso is a coach. He bets on a game of darts against a club owner. It's about a soccer team, an American who's going over to England for the soccer team, and the other team owner was Rupert. Ted's losing pretty badly on this game of darts and needs a near impossible score to win. And as he's about to throw, he talks about how guys have underestimated him his entire life. He shares that it used to bother him until he saw a Walt Whitman quote, "Be curious, not judgmental." And he continues the story and continues to score and says, all the fellows used to belittle me. Not a single one of them was curious. He shares how their judgments had nothing to do with him, because if they were curious, they would have asked the right questions. Questions like, have you played a lot of darts, Ted? So as he continues to throw darts and hit score after score, he confirms that he played a lot of darts actually with his father, and he hits a winning bullseye. Our takeaway here, curiosity is key. A key step in collaboration is to inquire. Ask the questions to find direction. Try to disentangle the impact of behavior on you and what you think other people's intentions might be. I always like to equate this to the email that you might receive. All of us, I think, have encountered this where you get an email and you read it with a tone. You read it with anger or excitement or, perhaps misconception. I often do what I like to say is save draft. Save draft means if I read an email that I think is an angry email typed and directed toward me, is to maybe type out a response on a separate document and then later take a breath, come back and reread it. And sometimes I realize that I've also misread that or misread or implied tone in my head that doesn't actually exist. The more we relieve other people of the need to defend themselves, the easier it is for them to hear what we're saying. It's about building and demonstrating empathy, strengthening working relationships between us and other disciplines. And then there's a strong likelihood that we all have the same intention, which is to do good by our students. Now that we've seen how working across disciplines benefits our students, let's take a look at how these same collaborative practices guide and support their journey into adult life and what those outcomes look like for secondary age students, especially as they fall off the cliff. So we're thinking about how we understand treatment, how we can collaboratively plan, and how we can recognize each other's expertise as well as cross-train. So let's talk a little bit about our secondary age students and about transition planning. So in terms of special education and behavior analysis, collaborative planning for the transition to adulthood is supposed to include determining the student's strengths, interests, assessing possible targeted outcomes that match the strengths and interest, and setting goals for building skills necessary to attain targeted outcomes and delivering services to teach those skills. From the perspective of the family, transition planning might also include things like financial planning, future thinking about where their child might live into adulthood as well. To give you an idea of some of the statistics that surround transition, about 500,000 autistic youth will enter adulthood within the next decade, and most of them will continue to need supports and services. The CDC updated their prevalence estimates, and the new report found that diagnostic criteria for autism adopted in 2013 made a slight difference in prevalence estimates. Autism prevalence was higher based on the older DSM definition of autism compared to the DSM-5. Future prevalence reports will continue to be fully based on the DSM-5 and will provide probably a better measure of the changing impact. But our nation really still lacks any reliable estimates of autism prevalence amongst adults. We know that this is a lifelong condition for most people, and it represents an unacceptable gap in our awareness of their needs and the resources, particularly such as ones like housing, employment, social inclusion. So each year, an estimated 50,000 teens with autism age out of school-based services. So this is often referred to as falling off the cliff. So parents often dread the transition from high school into adulthood, which is sometimes described as falling off the cliff. Here's why. Many autistic high school students get help through special education. They may get home-based services, community-based services. Each student has a team that decides what services are needed to prepare them for young adulthood. Federal law requires schools to offer these services. Then, the day after high school ends, the legal mandate for help suddenly ends. There's no federal requirement for providing supportive services in adulthood. Youth and their families have to apply for adult services that use completely different rules than special education. I would also add they use different acronyms. If you have worked in special education before as a behavior analyst, you will know that special ed is fraught with acronyms. Adult services use even more and different ones as well. The eligibility for many special ed supports in adulthood requires the individual having an intellectual disability. However, the majority of autistic youth don't have an intellectual disability, although their communication and social impairment may significantly interfere with their ability to get a job, as well as go to school or socialize. Transition services and supports are critical for guiding youth successfully toward their goals during this time of instability. Sometimes, though, help isn't available. This leaves families struggling to navigate on their own and results in too many youth failing to launch successfully into adulthood. The creation of effective and affordable programming tailored to meet the needs of 50,000 autistic individuals who leave high school each year, each with their own unique strengths, interests, and challenges, is an urgent task facing our society. Services for autistic youth seem the least available when they're most needed. And this is why parents often say their children are falling off of a cliff. During high school, Over half of youth receive speech therapy, occupational therapy, social work, case management, specialized transportation, or personal assistance. However, receipt of those services decreased dramatically between high school and early 20s. Approximately 20%, 6% of adults on the autism spectrum receive no services, which could help them become employed, continue with their education, or even live more independently. About 28% of young adults who were not employed and also not attending high school education had no services at all. And over one-third of autistic youth were disconnected, meaning they didn't transition either to employment or continuing education after high school. Why the decrease in participation? Several reasons for those. Um, Families face a lot of challenges as our students transition into adulthood. The participation of autistic youth in special ed services is a prerequisite for parental employment because most of these students need supervision and cannot be left alone during the day while a parent works. So parental employment in turn is imperative for family financial well-being. So upon exiting secondary school, autistic individuals enter the adult service system where there's no entitlements beyond the safety net provided by Medicaid or Social Security supplemental income. Both programs have strict asset income caps, and as we've seen pretty recently, those funds are also being greatly restricted and limited and reduced. Talk about a withdrawal design for our students. Chevelle and Strauss's population-based study to determine comparative mortality of persons with of autistic persons found that life expectancy was reduced somewhat compared to those with ASD to the general population, which is only by about 3 years, which means that a lot of needs go into planning for individuals who will live into their 90s. Reduced life expectancy with increasing severity of intellectual disability, and there's a notable increase in the mortality due to seizures, which is about a third of all individuals. So as I mentioned, over the next decade, about 500,000 teens in total, which was about 50,000 a year, will enter adulthood and age out uh, into adulthood and out of school-based services. So teens with autism receive healthcare transition services half as often as those with other specialized healthcare needs. Young people who are autistic are also coupled with associated medical problems are even less likely to receive transition support. And many young adults don't receive any health care after they stop seeing a pediatrician. By far, the most commonly studied predictor is the functioning level of autistic individuals, and that has been repeatedly shown to predict adult outcomes. Specifically, the functioning of autistic individuals related to cognition, language, communication skills, diagnostic severity, and self-care skills have been found to predict employment, residential independence, as well as social participation. Studies have shown that race can also predict differential outcomes of autistic youth as well. Without the inclusion of parental expectations, both family background and functional performance were significant and direct predictors of young adult outcome as well. So let's talk a little bit about aging, health and aging within the ASD population. As many as 70 to 75% of children and adults with autism, they're likely to have at least one mental health condition, as you can see here. Many of us have encountered this in the students and clients that we're serving, including epilepsy, chronic GI issues, food selectivity issues. About 60% of individuals have food selectivity issues, sleep issues. So compared with other students with developmental disabilities and typically developing children, 53% of autistic children have been noted to experience chronic sleep problems. These are all behaviors that we have the power to change early and get on those problems before our clients and students reach adulthood. How is this relevant to our practice as behavior analysts? The prevalence of such secondary health issues heightens that group's need for continuous health care and suggests that lapse in care can be particularly detrimental to their well-being. So it's really critical as behavior analysts that we start shaping and creating programming for these individuals who are going to be transitioning early that include practicing doing things like um, going to see doctors, desensitizing individuals to healthcare providers and to examination. So, getting your blood pressure taken, your temperature taken, blood draws, all those things that are required when you visit the doctor or dentist, even. That may include tactics like systematic approximations or desensitization, increasing opportunities to respond from routine medical care. For many of our students, we work on having them start with visiting the school nurse who's wearing a lab coat or other medical gear. A lot of our students have an immediate response to a loop from that area as soon as they see a medical professional. So sometimes it's just getting them to enter a different room, enter it with a medical professional, being able to have somebody use a stethoscope, for example, before we move to more intrusive things like using an otoscope where they're looking in their ear or taking their temperature. In addressing problem behaviors like pain attenuation, um, using the law of parsimony for ruling out potential medical issues, things like adolescence and puberty, which we frequently love to say bring out our greatest hits of problem behaviors that we have potentially seen before. And being able to program for generality and durability of these responses, making sure our students have the repertoires to engage in healthcare related behaviors. Let's talk a little bit more about health in family life, in the family quality of life. So there was a family quality of life survey, and they looked at conditions where the family's needs are met, the family's members enjoy their life together and have a chance to do things which are important to them. This is really about changing socially significant behaviors to a meaningful degree. It's part of our core definition of applied behavior analysis. So parents often need to learn new parenting strategies and how to advocate for post-secondary opportunities while also continuing to be a caregiver for their child. Although some individuals with ASD will lead their life without formal supports, a lot of them will not. These individuals are going to need lifelong assistance of their families and support services. So currently, many aging families and support services are simply unprepared for this aging population. Also of note are those who have not accessed the formal support system but need to as their families age beyond their capability to provide continued care, which is also about having some of those very, very difficult conversations with families about the level of support that they may need and getting them to think about what that support might look like when parents are 70, 80, 90, and unable to care for somebody who maybe requires substantial and significant support. So, in their synthesis of research on promoting family outcomes, Kaiser and colleagues identified four categories of salient support. One is emotional supports, or those pertaining to feelings of and affective considerations, the physical supports, material and instrumental supports like financial resources, being able to carry out tasks and responsibilities, and informational supports as well. Higher family quality of life ratings were found when youth had fewer challenging behaviors. So, well-designed interventions are needed to address challenging behaviors as part of comprehensive transition services and supports, as well as equipping families with the skills and strategies needed to address those behaviors at home. They also found that strength of religious faith was a predictor in family quality of life as well. So involvement in faith community might provide some parents with a context for accessing some of those social relationships, emotional support, and outside assistance that might be a little more elusive for them. For us as behavior analysts, this means shaping the teaching repertoires of parents to support behavior plans, assistive tech, and augmentative communication, being able to task analyze effectively to teach as well. In functional analyses of parent adherence to behavior plans, being able to shape behavior rather than doing for. And that is a hard thing as a behavior analyst. We often are working to fix these problems, but it's about behavior skills training. How do we effectively teach parents to find the answer to this? How do we teach them to implement these strategies as well? Being able to also task analyze the tasks of transition, presenting each piece in very manageable chunks for our families as they learn to take over and steer the car, if you will. And that includes us being able to teach parents basic principles, how important the function of behavior is, and how to find solutions once they understand the function. In doing so, again, while removing some of the jargon, some of the terms of our science that are not critical for them to learn. It's important for them to understand how to get to why is the student engaging in these problem behaviors? What do I need to do to address this? And most importantly, as professionals, especially for those of you who are doing community-based or home-based service provision, it's about prioritizing parent goals. Very often, parents will say, oh, I want to work on these academic goals. And not that those are not critical or important for our learners, but more important is, can the family effectively teach functional communication so that our students have voice and choice? Can they teach choice making? Can they address problem behaviors? And making those priorities now before they reach adulthood. That is a very critical. If our students cannot perform these skills and our families aren't empowered to do that, we have failed. It's also about connecting families to critical entitlements that they are going to need. As we've seen the landscape change, whether it's fiscally or politically, it's often the resources that families have may shift and adjust. So it is really critical that as a behavior analyst, you also inform yourself about access to the Office of Person with Developmental Disabilities, Access VR, guardianship, understanding the Medicaid waiver system, as well as Social Security supplemental income and disability income. Being able to inform yourself and learn about this outside the scope of just our discipline is really critical in connecting families with these entitlements and knowing what is available to them. As with any good government program, as you can imagine, none of these entitlements are easy to access. Even just qualifying for Medicaid waiver, where families can access things like different services. It could be respite care. It could be getting them a break from, when they need it most as their students, when they're young or when they've aged into adult services. It takes time to qualify for that. It takes evaluations. It takes scheduling. I would say that some of those processes take up to 2 years in total to get parents enrolled. So being able to become knowledgeable ourselves as behavior analysts is about helping our families become empowered to know what resources are available to them when they are going to need it most, and making sure that those pieces are in place before the student needs to access those services. I find too that families often wait to the last minute and they're like, oh, remember when you told me about these services that I could get? I need to get those now. And the hard part is that they're not overnight enrollments. They're not things that happen overnight. So we want to get them enrolled proactively, make sure that they're accessing these services proactively so that they're there when they need them. Our teaching, though, is in shaping of behaviors extends to social opportunities, which also lead to independence. Some of the stats for our students and clients can be a bit grim. So 53% of individuals have a guardian, meaning that their parents, when they turn 18, become legal guardians for decision making. That could be financial decision making, it can be medical decision making. And these are critical pieces for many students who need substantial support to have. Um, but their social opportunities are also very limited. So um, you can see about 76% saw friends, called friends, or were invited to activities. About 68% had any community participation. You can imagine for families and for the individuals we serve, this can be very isolating. There's a lot of comorbidity, though, that affects social opportunities. That includes things like environmental factors. Um, for many individuals who require very substantial support, there's minimal access to inclusive post-secondary educational opportunities. You need to be very independent. One of the most critical things over the years, I think, working with students who are aging into their 20s and now are in their 30s and 40s, is realizing that independence is king. Being able to even access and enroll in a rehabilitation program means that you have to be able to sit with the group, go with the flow, and entertain yourself. It's not all about your academic skills. It's about your ability to self-manage and to be independent. So, these environmental factors are affected by the student's independence. Those social opportunities can also be restricted. It becomes difficult to take individuals who have problem behavior to family functions, to social opportunities. A lot of families will avoid some of those new events and places because of problem behavior. And they unwittingly and inadvertently reinforce some maladaptive behaviors rather than providing some of those learning opportunities that can be garnered by social modeling or peers who do not have disabilities. And the last piece is there's a lack of appropriate levels of behavior support services and acceptance of persons' current behavioral repertoire by caregivers that sometimes hamper the development of self-awareness and socially appropriate behavior. So these are all components that we have to work on. A large number of studies have also reported that a lot of the individuals studied are very socially isolated and have minimal friendships. That lack of friendships in the population have also been associated with loneliness, depression, and anxiety as well. Participation in those social activities is limited, especially regarding group activities. If you can't sit with the group, you have limited functional communication skills, and then it becomes more and more, your world becomes smaller and smaller. So what are our critical teaching points here for our secondary age students and for our young students? Because I would say if you work with younger students, the things that you are teaching and the behaviors and repertoires that you're shaping now affect outcomes for an individual when they're 20, 30, 40, 50. It is critical that we focus on building functional communication skills, voice, and choice. Being able to increase use for communicative intent should be integrated early on in community-based settings. It's not enough for us to sit at the tiny desk in the apartment or in the school. We've got to get out in the community and really work on application of those skills and adduction of those skills, being able to combine all these repertoires that our students, we've worked to shape all these repertoires. Can they use them functionally in the scope of a shopping trip or going out to a social event in the larger community? Behavior matters, and failure to address those behaviors now will lead to diminished social opportunities later. So, severe disability has numerous connotations. Assuming people with disabilities are so globally impaired that they can't know what they want is a problem. We're assuming incompetence or failure, we fail to reinforce other communicative behaviors aside from vocal verbal. In increasing appropriate interaction, vocal verbal responses are reinforced, but other communication might be ignored. So understanding the communicative nature of problem behaviors and reinforcing alternative responses is very critical in increasing the opportunities for our students. As our students uh, transition into adulthood, many of them are living with families. This is probably one of the more challenging conversations to have with families. I've worked with many families who are brilliant professionals, brilliant people, and they very often will say, well, my kid's going to live with me till I die. And I'm like, wow, that is a huge life shift for them. So when you pass away, they're now going to have to go live somewhere else, away from everything they've ever known at age 70 or 80 or who knows what age, where their behavior, certain behaviors have developed and they're very difficult to change over that period of time. It's about getting parents to think about what will that individual's quality of life look like? What does it need to look like? And what will be the least jarring for them as they transition into their older years? So very often our students are living with their families. About half of individuals live with their families or parents. About 27% of them live in group homes. But the fact is, there's very little funding for services in a parent or a relative's home. There are some services and entitlements that we can get families enrolled in, but as you can imagine, that doesn't come close to covering the costs um, needed to care for an individual for their entire lifespan. So the proportion of adults living with disabilities living in their families' homes continues to grow. It's prompted by lengthening wait lists for out-of-home placements in most states. Some states, it's really when nobody else in your family is alive, then you are in line for a group home. And this trend has a lot of implications for transition age youth with disabilities, including those with autism. So well-documented difficulties in executive functioning among individuals contribute to the challenges they face in gaining the skills they need to live independently or with lower levels of supervision and support. Specifically, individuals have difficulty dealing with new situations, processing new complex information, as well as problem solving. Again, these are critical teaching points for us as behavior analysts and critical collaborative points. Again, coming back to our occupational therapists, this is their jam. They know a lot about habilitation. So really being able to combine our powers of the tactics of our research along with their knowledge of um, tactics, accommodations is really, really critical in helping our students and clients gain these skills as they age. As I mentioned before, in a world of limited residential options and placements, independence is king. Empirical evidence from both the world of ABA and transition suggests that tactics from our science are effective in shaping daily living skills. And they're even more effective when we pair together with speech pathologists and occupational therapists and physical therapists. This can include things like using visual schedules, electronic schedules, and programming for that. There's so many great apps and tools now for teaching our students how to follow these schedules to become more independent. Being able to fade our distance, fade reinforcement. If our students can only perform a skill with a dense schedule of reinforcement, we haven't done our job. We really need them to be able to perform these skills under the natural contingencies within the environment. Let's talk a little bit about work for our individuals. So about 14% of them are competitively employed, 38% supported or sheltered work settings, 4% have voluntary work or worked with family, and 42% attend day or residential units with no specific work. As you can imagine, that the job market is grim for individuals who have a need for very substantial levels of support. Similarly, about 74% of students, autistic students, graduate with a diploma. About 19% of autistic students graduate with their certificate, and about 8% don't finish high school at all. So very often, the individuals we are serving have very low rates of employment. They're working in segregated work settings, often menial jobs and low wages and hours. even when compared to people with other disabilities. The things I would encourage you as behavior analysts to reach across those lines of collaboration is to understand what are the jobs that are going to exist. If it's going to take you 5 years to shape a set of work skills, you better be sure that that job is going to still exist. As you can imagine, the job market is changing rapidly. Things are becoming computerized. Artificial intelligence is taking over some of these like small tasks. Very often, it's about getting to know organizations. Here in New York City, there's an organization called Job Path where they work on different supported employment models. And some of the collaboration we've done is reaching out to them and saying, what does the job market look like for individuals with significant levels of need and support? What jobs do you see them getting, or volunteer opportunities do you see them getting? And then teaching for those jobs and repertoires. Because very often we were teaching and shaping things like office skills that we thought would be really valuable. And they were like, nobody gets office jobs anymore. That's a really hard job to get. So it's about thinking about what will the environment look like in the future for them, especially if we're going to spend several years teaching them. We don't want it to be for an obsolete job. Very often, a lot of these individuals are particularly at risk about within the first 2 years after leaving high school. Because many autistic adults live in supported settings, they have limited engagement in employment. They start to lose motivation for that, as well as the skills. When I had a family reach out to me recently of a student who graduated several years ago, the mom said to me, what do you think about having using these funds to have a behavior analyst come in? She was a parent who truly loves ABA and sees the value of ABA in everything her son learned to do. But he attends a day program, and she had started to see some of his skills slide. So she said, I think it's time to think about how to get him back into some of those routines and using a lot of the strategies of applied behavior analysis. And, can you help me think about ways that we can use funding for that? So I think it's about when our students are aging out, making sure, again, the parents know how to access those services and they know when to come back or when to add in a layer of therapists or services that might help their student get to the next level, even at the adult level. For most autistic youth, employment upon graduation from high school and college is pretty elusive. Data from the National Longitudinal Transition Study support poor post-school outcomes. Shattuck and company found that the majority of students with autism spectrum disorder were not employed or engaged in post-secondary education after leaving high school. And functional skills were a predictor for most post-school outcomes. Income was a predictor for most specific outcomes as well. Research by Taylor and Seltzer found students without intellectual disabilities were more likely to be competitively employed. They note that for youth with autism, unemployment after school ranges from 50 to up to 86%. This is an unacceptable outcome after years and years of specialized schooling and services that we all provide. It suggests, too, that a curriculum is perhaps not as influential as other in-school experiences. So let's take a look at, does curriculum matter? So functional curricula are usually used to conceptualize, focus on life skills, those ones we need for living, working, partaking in leisure skills in the community. Functional communications are multifaceted, consisting of functional academics, vocational education, community access, daily living, financial skills, independent living skills, transportation, and social relationship skills and self-determination. So only about 25% of students who participated in the National Longitudinal Transitional Survey received a functional curricula. While the curriculum was not influential, the functional skills were a predictor of post-school outcomes. These are things that we can capitalize on. These are behaviors that we can shape and teach, right? So one really great model was the project search model, which was a intensive business-based internship collaboration model embedded into the final years of students' high school experiences. It utilized ABA to teach a lot of the core skills, involved 21 autistic individuals in the treatment group that were hired into competitive employments in jobs such as pharmacy techs, ICU assistants, teacher's aides, surgical care, and clerical assistants. And their wages earned by that group were 24% above the minimum. Um, and 78% of the clients maintained competitive employment and were able to increase their wages. So these were students who required significant staff time and extraordinary supports, including things like one-to-one staffing ratios, extensive behavior supports prior to entering the study. So usually those students have been identified as having behavior challenges among the team are the most likely to have difficulty transitioning into employment. Yet, after a year of this project, plus ASD supports and intervention, they not only successfully completed the internships, but they gained and retained competitive employment, much higher than those in a control group. One reason for the success of this project was the collaboration of all the partners mentioned. On-site administrative teams worked together to meet the needs of both student and businesses on a daily basis. The entire team met together on a monthly basis to raise concerns regarding the interns, classroom instruction, internship sites, and brainstorm solutions and celebrate successes. Integral to the project's success was the implementation of ABA and positive behavior support. The participants' instructional and behavior plans were individualized based on behavior assessment, and additionally, there was an intensive focus on the contextual fit of individualized instructional interventions in the business environment. The application of behavior analysis, participants in the treatment conditions had the opportunity to practice specific job skills in a generalized setting with a high number of opportunities to respond so that mastery, fluency, and generalization of the skills was guaranteed through the model itself. So, what are some of our predictors of successful transition? For those with ASD, this means acquiring skills in academic, socialization, self-management. Our students need to be able to demonstrate competence by fluidly and fluently applying knowledge in a variety of real-life environments. Participants need to include the parents, the students, and the entire transdisciplinary team. And focus on goals that are specifically developed for the individual that focus on a functional nature. So that might include being able to utilize your reading skills to and math skills to follow a recipe, for example. It's great. Can you do a leveled reader? Super. But can you use those reading skills to complete a work task or complete making a meal for yourself? So, focusing on those functional life skills each in our goals. The other piece is promoting self-determination. So when we talk about self-determination, we're talking about something that's functionally rooted in determinism. It's about acting volitionally rather than being coerced or forced. It emerges across the lifespan as kids and adolescents learn skills and develop attitudes that enable them to be causal agents in their lives. Self-determination can be defined as the person's self-awareness and overall autonomy, and having the ability to act as an agent in your life, be able to maintain or improve your own quality of life. Specifically, it's about individuals who exhibit well-developed self-determination. They're capable of making choices, engaging in decision-making and problem-solving and goal-setting, self-evaluation, self-instruction, and self-knowledge. These are critical pieces that we need to incorporate early on in our functional communication targets, along with those speech therapists and occupational therapists and physical therapists. That includes being able to incorporate things like decision-making, choice-making, problem-solving, and independent living. You can see where these transcend each of our disciplinary areas. So why are students who are on the autism spectrum lacking self-determination repertoires? Well, we know they have difficulties with their communication skills. They lack a lot of the self-care skills. They often haven't, those repertoires for self-advocacy have not been shaped. They often have delays in cognitive processes or theory of mind, difficulty with other central coherence or context, and difficulties with executive functioning. Some of our tactics for continuing to increase some of these repertoires can be can be applied to self-determination. So we can utilize our principles, whether it's prompting, task analysis, modeling, shaping, chaining, to teach choice making. Most importantly, it's about teaching the scope of choices. Very often I find the students that I work with, if you ask them what they like, even in a job, they don't know the scope of choices out there. So I had a student once who he loved farm animals. And so when you would ask him what he wanted to do, if we did, say, a career assessment with him and we did some interviewing, he would often say, I want to work on a farm. I want to work with animals. And the truth is, he didn't like working with animals. He just likes animals. He likes to draw them specifically, but he didn't understand what the scope of work looked like on a farm or working with animals. So, and very often our students don't know what the scope of job options are. So it's about utilizing tactics like sampling, having our students try some of these things out early so that they have the opportunity to see what they like and then work on skill building. And it's about generality across settings, persons, times, and interacting with communicative partners. So what are our pathway to collaboration? Over the next few slides, I thought it would be helpful to focus on suggestions that provide a framework for collaborative practices that we have found to be pretty instrumental at least in my work experience. I would say many thanks to the pandemic. We are all utilizing a lot of platforms for collaboration, which provide a lot of structure for shared goals, responsibilities, all those things that we talked about earlier that are key factors in collaboration. Um, these established alternative modes of collaboration can go beyond email or in-person meetings, which is really critical because time is of the essence. None of us have so much time in our schedule across all the clients and students that we serve, often for all of these meetings. So we utilize things like Microsoft Teams to aid in sharing of information and having a platform where each person on a transdisciplinary team can access that. Often time is a barrier to collaboration. We establish set times for speech, ABA, OT to meet. Clinics with families are run with a shared agenda. We formulate that in advance, including asking the parent what they want to prioritize. Again, coming back to how are we going to prioritize helping our families help our students become independent? We have to prioritize their goals in the home and community as well. Instead of us just presenting what we've been working on, it's thinking about where do we cross over, which also keeps us focused on those collaborative, meaningful goals, is knowing that, okay, we're all working on these functional communication targets. And how does that apply to a PT session or OT session? How does that apply in the home? And us talking about what those targets look like collaboratively so that we can maximize opportunities to respond so our students become more independent. This also includes things like being able to, within a school setting at least, run groups more collaboratively, having buy-in from every group. We have groups in our program that run collaboratively between speech, occupational therapy, and ABA. Everybody is part of that planning and service delivery. And it allows us to do things like target life skills or real world application of skills. So we've been teaching our students health and safety behaviors, for example. So one of the things we focused on in a group was teaching them how does that apply to first responders? How do you identify when you need help with something? Using functional communication to indicate needing help. Being able to interact with first responders so that those groups also across many weeks incorporated some first responders here in New York City coming and visiting and our students getting to interact with them firsthand and practice engaging with them and practice engaging in functional communication, being able to respond with your basic personal information. and becoming more comfortable with these individuals should they encounter them. So it's critical for our secondary age students who need to be able to functionally apply these skills and engage in induction, pulling together all those repertoires that we've spent time building to actually use the skills, which is going to be valuable first and foremost to our students slash client, and then secondary to that, to their families. If we can put aside our feeling of wanting to be in charge and territorial with roles and responsibilities, including a collaborative assessment, goal formation, and foundation, we have pathways to collaboration. We can use data analysis as our form for being open-minded, trying out strategies from other disciplines, as long as we can use data as a way to say, is this effective for the learner? And keeping that learner's progress at the forefront of all of our discussions. Also, assessing for a transition, whether there's a variety of different assessment tools. I'm happy to share, the names of those as well. Some of them are free, some of them do cost money, but there are a variety of ones that you can do collaboratively so that we can focus on things like self-determination, interests, making sure that we are promoting voice and choice, and sharing our goals through documents and spreadsheets. We've gone to even planning our goals collaboratively on one document so that we can see, okay, these are going to be our verbal behavior targets or functional communication targets, and making sure that we're all going to address that across each respective discipline. And some of that also includes things like preparing portfolios through tools like Google Docs, even creating a transition portfolio of all the skills that our students are able to do so that when they go to transition out, we can help build their resume. We can look at our long-term trajectory. We also have tried to program for collaborative sessions, even within the scope of independent providers, having sessions where we overlap across disciplines and take structured notes is a way for us to cross over into each area, each domain, and think about how are we going to teach those repertoires, how are we going to shape those skills in our own sessions. We also set aside time for transdisciplinary meetings where we discuss those goals, discuss the targets, the programming concerns. Those collaborative sessions also give that moment-to-moment, more frequent opportunity to engage with each other professionally. So we see what they're trying to achieve. We see where maybe the inconsistencies are, which is really critical to student progress. It also allows us to be on the same page when we sit in front of a parent. We all have a unified approach to prioritization of goals, to what we're working on, and the parent is a partner in that process. So we created design structured opportunities for overlap as well as question asking. I would also say for those of you out in the field, sometimes it's about having collaboration through videos. So you can see what that modeling or use of the assistive tech device looks like, using Teams, using shortcut sheets for behavior intervention plans so that with really clear pathways for how a therapist should respond while following the behavior intervention plan. Frequency matters. If our students don't acquire skills, it's because we haven't given them enough opportunities to respond. So the more we're collaborating, the more often we're going to be better at collaborating, the more often our students are going to acquire these skills because we're all doing this together. So I think in addition to the pathways, it's helpful when we think about the intersection of compassionate care, ethics, stakeholders, and meaningful action. And the last couple of slides here, I just want to focus on distinct concepts that summarize the intersection of meaningful collaboration. And the first action we engage in is humble collaboration, respecting knowledge and expertise of other professionals as well as caregivers. In this perspective, taking can be achieved by expanding our own knowledge about what other people's expertise is, asking questions of caregivers and respecting their own personal histories with their kids and the individuals we serve, which will help us provide more effective and thoughtful services. The second includes the role of socially significant behaviors and collaborative practices. To effectively provide services that will promote inclusion and independence for our students and clients, we need to ask the right questions and demonstrate perspective taking across the entire team to help ensure that our students are meeting those goals. And finally, effective collaboration includes respecting and actively promoting clients' self-determination to the best of their abilities, particularly when providing services to vulnerable populations. Promoting our voice and choice. How do we collaborate? Remain steadfast to our scope of practice and competence, respect others' professional expertise, and ensure that everybody has an opportunity for meaningful contribution at the table. Our students have global skills and deficits, which means one single strategy or method is not going to cut it. In ensuring that the parents are partners in our collaboration so that our goals have social significance to the student and family. Our goals and our progress and independence for our students, we're all stronger together. Finally, to ensure our social validity, we have to ensure that interventions align with the real world needs and preferences. It prioritizes meaningful outcomes for those secondary age students, especially those who need a lot of support, and it values the input from the entire team, as well as promoting culturally responsive and person-centered collaboration. And finally, it's about involving students in goals and in goal-setting meetings, making sure we're including the perspectives of other autistic individuals. We recently had a student whose family wanted us to share with him that he is autistic himself. And we wanted to be thoughtful about how to approach that. So we actually sought out a behavior analyst who is autistic as well to get some guidance on like how do we approach that? What's the thoughtful way to do that? So thinking about it from that perspective as well is how do we include self-advocates in this process when we formulate meaningful goals? And using interest-based assessments to guide our programming, conducting regular feedback from families, other professionals as well, and students, and making sure our instruction reflects cultural and personal relevance. The final piece I want to leave you with here is that I love this when we look at papers and studies that are valid and reliable. If you see that last one on the top row there, what is both reliable and valid, you notice it matches those interdisciplinary and transdisciplinary models. When we work together, we're going to have more reliable and valid results from the skills that we're trying to teach when we all work together. There's room in the sandbox for everybody. It all works better when we play nice. Thank you guys so much for coming today, and I appreciate your attendance.
Well, thank you, Amy. Fantastic presentation. Thank you, everyone, for joining. If you do have any questions, please post them in the Q&A so I can send them to her after the presentation. I will stay on for a few extra minutes in case anybody does have any additional questions, but thank you, Amy, so much. And I hope you have